Good evening, all the aspirants present here. So, today is our first session of General Topic CCS session, and the speaker that we have here is Dr. Fathy Elshazly. He is a specialty registrar in Northwest Deanery, NHS, England. Thank you, sir. So, you may continue.
Okay, thank you so much for having me. Um, Thank you, Fatma. I'll start sharing now. Could you see the
Yes, sir.
presentation?
The slides are visible. Just put it in the slideshow mode.
Okay, you can see it now?
Yes, sir, you can start. And so many other
Okay,
students will be also joining us. And all the
okay,
aspirants, it's an interactive session, so you can also unmute your mic or you can type your question or any doubts in the chat box. Thank you. So you can start.
yes, thank you so much. As mentioned by Fatma, this is supposed to be an interactive session. To get maximum benefit out of it, I ask you kindly, I cannot see your names at the moment. I only could register three, Stani, Arsha, and Salah. If you don't mind, just unmute your microphones and if you can open your camera so that can be some sort of interactive session, because if you are not going to interact, the benefit will not be so much from this kind of scenario. As you know, the EDIC exam contains is being run over 2 days. The first day is computer-based scenarios with just slides, about 10 slides in biochemistry, 10 slides in radiology, and 10 slides uh, in curves, whether ECG or ventilator curves or TEG or ROTEM, and those kinds of computer-based questions are the most difficult actually, because you have to answer a lot of questions in a short period of time, and then you have to at least pass 2 stations out of 3. Regarding the second day, which we are going to practice today, is the clinical case scenario, where you are going to have 2 short cases and 2 long cases. And the 2 short cases, every case takes about 20 minutes, and the long cases, everyone takes about 40 minutes. The examiners are going to take you into a journey from the time you encounter the patient until the time they being discharged from the ITU, or God forbid, the time they die. If the patient dies or deteriorate during the exam, don't get panic or anything. This might be most probably the scenario itself, because actually the process of death or end of life care is a process that you are being examined as well. They are going to assess how we are going to deal with the patient in this situation, and how we are going to deal with the family in this situation as well. So because there is no communication part of this exam, they are going to assess your communication skills and your approach to a patient who is dying or end of life care. In purpose, I did not announce or the case of which we are going to discuss today, because we're going to discuss a lot of aspects, from whether resuscitating the patient, what are we going to do in admission to the patient to reach the proper diagnosis, and how we are going to treat the patient properly, and during his journey or length of stay in the ICU. So I would really approach if you can engage with me in this scenario, because if you are not engaged, because this is all about the practice. The EDIC exam is not an exam just to assess your safety and if you have practiced ICU or not. Those kind of courses are not going to teach you ICU from scratch. The information and knowledge, I know it is there. I know that most of you have been practicing ICU for a longer time, but this exam is only about how safe you are according to the European standards. Um, so let's start. Could anyone please volunteer to read the scenario, if you don't mind?
18 years female who's been unwell for 3 weeks with bumpy swellings around neck, nodes around the neck and behind the ears, pyrexia more than 38 degrees Celsius. Visited outpatient department, treated as glandular fever, advised some rest and hydration, was given paracetamol and some spray, felt better going to school, college. 2 days ago started feeling tired or lethargic.
Okay.
Admitted
continue,
to
please.
emergency department into the medical ward and was treated as probable viral infection. You are asked to assess the patient due to hypotension requiring multiple fluid boluses, increased respiratory distress, 94% on NRBM, 15 liters per minute, decrease in the level of consciousness, GCS 14 out of 15. What are you going to do?
So what are you going to do? What's your name, sir? Sorry, Stani or Arsha? What's your name, please?
I'm Dr. Priyanka. So I
Priyanka,
would like
okay.
to resuscitate the patient. I will take care of the airway, breathing, and circulation. And
Yes,
so I'll take
continue.
care of the airway, breathing, and circulation. So if the patient is not maintaining the airway or reduced level of consciousness, then I'll put a mouth gag or some similar device to open the airway and give oxygen. Try to maintain saturation above 94%. And then circulation, patient is having reduced blood pressure also. So I will give fluid boluses and maybe required. I'll like to start with vasopressors. I will prefer noradrenaline over vasopressin. Um, and also,
Okay. Okay, so what kind of fluids are you going to give to the patient? And what's the dose?
so I'll prefer crystalloids over colloids, preferably balanced salt solutions over the normal saline. And I would, my resuscitation will be individualized as per the patient, and I will be guided in my fluid resuscitation by the measures of fluid resuscitation. And so I'll measure echocardiography and measure the cardiac output with the help of echo bedside focus. And then I will like to look at VTI, and my fluid resuscitation will be guided by changes in VTI.
Okay, so what are you going to do next with the patient then?
Because this patient is also having respiratory distress, so I'll because NRBM is not good, so I will like to put either the patient on HFNC or non-invasive ventilation. I'll prefer HF, high flow nasal cannula, over non-invasive
Okay,
ventilation, and
okay,
maybe I'll
great.
try to give a trial.
You are still on the medical ward. Are you going to continue treating the patient on the medical ward?
No, the patient requires ICU admission, definitely.
Okay. How are you going to ensure that she's safe to be transferred to the ICU then? Hello?
How? Yeah, yes, sir. How to
Um,
ensure patient is safe for the transfer? Uh,
mhm.
because this patient requires vasopressors and the respiratory support is also required. So this cannot be managed in the ward setting. So patient requires the ICU admission. We also have several scoring systems like Quick SOFA score, Muse and News, early warning scores, which help us to guide regarding the ICU admission policy of the hospital. So this patient
Great,
is
great,
having
great.
GCS low, so neurological system is affected, respiratory system is also affected, and plus hypotension. So cardio, three systems are being affected in this patient. So that definitely the patient requires ICU admission.
Okay, so great. You mentioned she requires ICU admission. So the issue that we are going to reassess again after the interventions you have done to see if the patient will be safe, whether the blood pressure has been stabilized, the patient not in a peri-arrest status, and he can be transferred safely to the ICU or ITU. Especially that the nasal high flow, usually most of the devices with the nasal high flow at the moment don't have internal batteries. So either you are going to use non-rebreather mask or NIV in order to transfer the patient and do what's called a checklist for transferring the patient and get a senior help if needed, okay? And of course, if they ask about what kind of help you are going to ask for, then the next question will be either from a colleague or senior colleague or from an outreach team or the outreach nurse or outreach team. Great, Priyanka. Obviously, you are very acquainted or very familiar with the system in Europe and in UK, especially because actually now the questions are being more more like have a British some sort of a British kind of questions because obviously the British obviously have some sort of dominated the exam process for pragmatic and logistic reasons. So to ensure that most of the aspirants of EDIC are usually go to UK or Ireland. That's why the exam is in English. So that's why the European Society of Intensive Care usually now use British examiners a lot and the British kind of questions. That was great, actually, Stani. Thank you so much. So I would appreciate if another volunteer comes, gets in and continue the scenario, please. The patient now was admitted into the ICU. She has received 2 liters of crystalloids and attached to nasal high flow, as mentioned by Priyanka, 60 liters per minute. Her respiratory rate remains above 35 and GCS dropped to 13. What are you going to do next? Hello? Anyone else would like to volunteer? Priyanka, would you like to answer this question?
Yeah, sure,
If
sir.
no one else would like to jump in?
So basically, when we put a patient on nasal high flow, we monitor ROX index, which is SpO2 divided by FiO2 divided by the respiratory rate. So I will like to monitor ROX indexes in this patient, and since tachypnea is worsening, GCS is also falling, then I will consider intubation in this patient. I will take consent for intubation, and I will intubate this patient.
Okay. What kind of consent are you going to have? If the patient, does the patient have capacity?
So all critically ill patients, they are having poor reserves. So we should always think about hypotension and hypoxemia post intubation. So I will keep my vasopressor infusions and in hand, and also fluids in hand before intubation. And also there is a risk of hypoxemia in this patient because the saturation is low. So I will keep all those things in mind and take a high risk consent regarding intubation.
But what kind of consent? Does you need consent? If the patient doesn't have a family around, would you really need a consent?
No, then I'll proceed with intubation.
Okay. What are the steps of safe intubation in this case? You mentioned some of them, but could you be more precise, if you don't mind? You mentioned already a lot of things that obviously you are very aware of the consequences of intubation in this patient. So, but
So all critically ill patients are considered difficult airway patients, and we can all these patients, they often have hypotension and hypoxemia in the post intubation period. So vasopressors and fluids should be kept in hand. Also, I will consider keeping difficult airway cart with me, because all of them, they are difficult airway patients, and I will intubate this
what's in the
patient.
difficult airway cart? What's in the difficult airway cart? Are you going to consider?
Stellate, bougies, and video laryngoscope.
Okay, that's good.
Also, as ICU patients, they should be intubated in semi-Fowler position, and rapid sequence induction should be used with cricoid pressure, because the patient can be full stomach also.
Great, great, Priyanka. Where do you work, Priyanka? Where
I
do you
work
currently? Sorry?
Delhi, sir.
Delhi, that's good. Very good. Very good, Priyanka. Actually, it's very impressive. You mentioned most of the things, but just to think in the European kind of way, or to be more precise, the British kind of way, they like everything to be written down. So that can be objective to and unified kind of practice to all the clinicians. And that's why they're using what's called checklist. Any patient who is being intubated inside the ICU, they are using what's called checklist. There are no guidelines from the European Society of Intensive Care Society about intubation, because already there are many guidelines, whether from European Society of Anesthesia or the American Society of Anesthetists. So most of the ICM societies, whether in North America or in Europe, they don't have their own guidelines for intubation. But in UK, and including the UK, but the UK, they have guidelines for pre-intubation and how to prepare for intubation. This is one of the checklists which is most commonly being used in UK, for example. It's being approved by the Intensive Care Society, the Royal College of Anesthetists, and Faculty of Intensive Care Medicine. And these are the recommendations that how to prepare the patient, prepare the equipment, prepare the team, and prepare for any difficulties. And they always like to divide everything into tiers, tier 1, tier 2, tier 3. So prepare the patient, IV or IO access, optimize the position, as you mentioned, a hard mattress or semi-recumbent position, airway assessment, optimal pre-oxygenation, optimize patient status, and to assess for any allergies. For example, if patient have got history of hyperthermia, it wouldn't be suitable to give him Saxonil, for example. And the same for prepare the patient, for prepare your equipment, as you mentioned, bougie, video laryngoscope, bougie or stylet, and consider the drugs which are going to use, whether you're going to use propofol, or in case of this hypotension, propofol might be appropriate. You might need to use ketamine. But if you have going to use propofol or any other, or sodium thiopental sodium, then you might think about having vasopressors in hand. Here they like to use either phenylephrine or metronidazole. Both are alpha stimulants, just in case if you want to give them boluses of vasopressors. And then prepare the team. Have everyone should be assigned. There should be a team leader other than the intubator. There should be assigned the first intubator, second intubator, a cricoid pressure if needed, and one for the drugs who can give the drugs, and the runner if you need a runner. And then if the patient, what are going to do if kind of failed intubation? Of course, in the ICU, most of the time, the waking up the patient wouldn't be appropriate, so we might go for the front of neck axis, which is cricothyroidotomy most of the time. This is the same checklist, but in a little bit simplified and more appealing. It's the same checklist which I've shown in the previous slide, but it's being used a lot in a lot of trusts and hospitals here in UK as well, which is called PEAS. FONA for Salah. FONA means front of neck axis. Front of neck axis, which is cricothyroidotomy. Okay. Or tracheostomy if appropriate. But usually for the emergency situations, we use cricothyroidotomy. And of course, this is which is being used for the rapid sequence induction checklist. It's called rapid sequence induction checklist, or PEAS. And then there is what's called the Difficult Airway Society guidelines for intubation in critical ill patient. It is the same steps that you mentioned, Priyanka, but it's just being systemized into steps. Pre-oxygenation and checklist, plan A, and of course, in every time you are going to attempt to do something, you should, for example, if you tried the first attempt with direct laryngoscopy, but it didn't work, in the second attempt, you have to use something else. Whether use the bougie, use what's called the PERP technique. PERP technique means adjustment of the upward and backward adjustment of the laryngeal airway, larynx, or use video laryngoscopy. And then plan B, if that fails, which usually you're going to use supraglottic airway, like a laryngeal mask airway, or iGel, which iGel is the same like laryngeal mask, but a modified or advanced type of laryngeal mask. It doesn't have to be inflated with air, unlike laryngeal mask. And then plan C, if you cannot do it, you are going to put the oropharyngeal airway, which they call it Guidel sometimes here, oropharyngeal airway or nasopharyngeal airway, whatever appropriate, and start bagging the patient and declare that the patient cannot intubate, cannot oxygenate, or until you call for help. If this doesn't work, declare cannot intubate, cannot oxygenate, and then go for front of neck axis. Of course, usually in the critical care, there usually should be 2 intubators at least, if appropriate, for proper procedure to be done. It's not a very exhaustive checklist. It's very easy to read it in 5 minutes. But I'm not asking you to know it by heart, word by word, but at least know the concept, know the steps that you are going to take, because they like this kind of actions, and they like to always, in this exam, they're trying to assess your safety. So if you are going to use the checklist, if you are going to mention that the tiers or the plan you are going to go, especially if you are going to mention what's called either European Society of Anesthetists guidelines or Difficult Air Society guidelines, it's going to give them some give you some sort of credibility for the examiners. So you intubated the patient safely, and then you asked for some blood to be taken. What kind of lab investigation would you ask for? Any other volunteers?
Blood investigations such as hemogram, renal function test, liver function test, coagulogram, and radiological is the 2D echo, IVC collapsibility, at the same time X-ray.
Okay.
These are the investigations. Also, after intubation, to send the ET secretions for culture sensitivity, gram stain, Zn stain, calcofluor, blood culture, ABG, to see the trend of lactates and gas exchange along with acid base status. These investigations we will ask for.
Okay, great. That's great. That's great. That's the same routine which we use with any patient being admitted into the ITU. Send for the basic labs, complete blood count, renal function test, liver function test, septic screen, including tracheal aspirate, and maybe blood culture, blood gas analysis to look for the gas, for the electrolyte disturbance or the pH, BCO2, BO2, and the lactate as mentioned. That's great. And of course, to do bedside
And
echo.
procalcitonin.
And procalcitonin, great, procalcitonin as well. And CRP. Anything else would you think about? What is the initial diagnosis of this patient? What's the preliminary diagnosis of this patient? She had glandular fever. What kind of differential diagnosis for glandular fever? What kind of glandular fever or viral glandular fever, which is very common? Any thoughts? By the way, in the exam, there are no negative marks. There are no negative marks. If you are being asked, the worst thing you can do is to stop talking and not answering the examiner. There is no shame in saying, I don't know, or I don't remember. But the worst thing you can do is to stop talking and keep silent during the exam. It's not a good sign at all. Because exam, what is clinical case scenario is just a rehearsal to what you are doing every day in your practice. At least, I know all of you working in ICU, and at least you have got one patient who is not being diagnosed yet. And you are trying to look for a proper diagnosis for it. So don't be afraid of saying something stupid or something or sounds stupid or something that might be wrong. Just say what you feel. They are not going to take any negative marks against you. Okay?
Sir,
Whether
can
if you say something right, they are going to check it as right. If I'm not going to say something wrong, nothing happens. Okay? But or if you don't know at all, say I don't remember anything at the moment, but that's what I can say, nothing in my mind at the moment. That's it. But please don't keep silent in the exam. Okay? So any other investigations do you think about? Any other lab investigations do you think about?
Respiratory virus screen, respiratory panel.
Respiratory panel, respiratory viral screen panel, you mean, right? Respiratory virus. Okay. So what kind of glandular fever you are going to think of? What kind of virus you are looking for? The microbiologist is going to call you and asking you, what are you looking for?
Epstein-Barr virus causing infectious mononucleosis.
Very great. Great. That's it. See, you could see that's the bloods of the patient. Okay. Have a look at it. And then when you are ready, just ask me to go to the other slide. As mentioned, the CBC was done. Ferritin was done as well. Triglycerides was done. Fibrinogen were done. CRP and ESR mildly elevated. The ALT and AST markedly elevated. elevated. LDH markedly elevated. INR 1.8. D-dimer elevated. Blood culture negative. ABV, CMV positive for Epstein-Barr virus, as mentioned by Priyanka, and pregnancy test negative. Remember always any female patient in the in the fertile period or should always ask for menstrual history and take pregnancy tests. Okay? Always remember this. Any female patient in the fertile period should have pregnancy test being done for her, or at least mention it, consider it after consent as well. Okay? Are you ready for the next slide?
Yes, sir.
Ready? Okay. So what's your differential diagnosis now?
So infectious mononucleosis.
Okay.
This could be HLH hemophagocyte lymphohistiocytosis because ferritin was high in serum.
Okay, great. What else? What else?
This could be tuberculosis because lymph nodes are enlarged.
Okay, great. Anything else?
This could be malignancy also.
Malignancy, what kind of malignancy are you looking
Hodgkin.
for? Hodgkin or non-Hodgkin lymphoma. Great.
Hodgkin.
That's it. That's some of the differential diagnosis, but you mentioned, if you mentioned the first one, then most probably you know that you pass this station, that HLH, triggered by Epstein-Barr virus, sepsis, of course, any sepsis with multiple organ dysfunction can cause this. Macrophage activation syndrome, it is considered the old name for the HLH, hemophagocytic lymphangioschistocytosis. This is considered the historical term now, but still being used in some textbooks. Leukemia or lymphoma, as you mentioned, and maybe rheumatological illness like systemic autoimmune disease, and of course, after this, you can mention anything you want, like tuberculosis. Any other investigation you'd like to do? You did the chest X-ray, the tube in place.
Ultrasound abdomen to look for splenomegaly because now we are thinking.
Ultrasound abdomen, okay. Anything else?
Focus lung ultrasound to look for
Focus lung
chest.
ultrasound, okay. So, as you mentioned,
Definitely.
chest X-ray, CT, thorax and abdomen and pelvis, and biopsy from the lymph node or the bone marrow. Of course, this kind of biopsy either to be radiological taken by radiologist under ultrasound or CT, or the bone marrow will be taken by hematologist. Sometimes need to go to the operating room or operating theater to be taken. Okay, so this is a CT chest. What's your comment about it? Anyone? Anyone?
So we can see
This
reticular
high resolution CT show
Yes.
infiltration. High resolution CT show infiltration in the fissure. Maybe fusion, maybe this consolidation in the right side.
Great. Yes. What else?
reticulonodular pattern in the rest of the lungs.
Great. Reticulonodular infiltrations. So this is a CT abdomen. What can you see in it?
Splenomegaly.
Splenomegaly. Great. So the CT thorax, as you mentioned, interlobar septal thickening with new small right-sided pleural effusion that may be related to the fluid overload. And there is a patchy ground glass calcification and mononodules, which might be secondary to inflammatory changes. And of course, the CT abdomen pelvis, as you mentioned, there is splenomegaly and there is abdominopelvic and inguinal lymphadenopathy, which is consistent with infectious mononucleosis, in addition to heterogeneous liver, which might be secondary to lymphoproliferative disorder as well. But there is no lung, hepatic abscess or any focal lesions. So the HLH, the patient has been diagnosed by HLH. There are two main scoring systems for HLH. This is the HLH 2004 and what's called the H score. The HLH 2004 is very little bit more complicated, and in order to be assessed, you need to do some sort of pathological and biological analysis of the cells itself, and that's why it's more being validated in children and adolescents. Okay. A score of 5, more than 5 results in the diagnosis of HLH, and you can start treatment. But you shouldn't wait for the pathological analysis to start with treatment, because most of those patients are usually in a very poor condition and needs and needs the CT findings again. The CT, the main thing here in the CT, you will find the splenomegaly, which is obviously large in this cut. In addition, according to the CT, you will not find the lymphadenopathy, but because I cannot bring the all cuts in the lecture, but you will find at least some sort of periportal edema and what's called heterogeneous liver, meaning it's not homogeneous like it used to be. Regarding the CT, as mentioned by Salah, you can find the pleural effusion here, okay, and some nodules all over, which most properly represent lymphonodular infiltrations. There are no clear patch of infections in this kind of CT, okay? And of course, in order to comment on the CT properly, you have to have multiple axial cuts as well, and the coronal cuts. So this is what we can, this is just give you the gross idea about the CT. Just because it's not some sort of detailed CT. And in the exam, they're not going to ask you for a lot of details, especially when they are asking for the CT. Just we're going to ask you to the frank set for the frank findings. For example, here, if you say that nodules, some cavitations or cysts, and pleural effusion, that would be more than enough for them. Regarding the scoring system, as I mentioned, HLH 2004, usually the children in the West are those who are less than 18. So any patient less than 18 is being treated in a children's hospital or in a pediatric ICU. So we can apply for this young lady, we can apply this kind of HLH 2004 as well. Or what's called the H-score, which is being usually more in adults. The H-score is much more simpler than the and more clinical than the HLH 2004, which we need pathological analysis in it. So how we can diagnose the HLH? First, there is a molecular or genetic diagnosis consistent with HLH, because there are two types of HLH. There is genetic predisposition or familiar type, and there is what's called acquired type. And in order to fulfillment, according to the HLH 2004, we should have 5 out of the 8 criteria listed below. The clinical criteria are fever and splenomegaly, which are both here, both in this young lady. And then we have the laboratory criteria, which is cytopenia. Cytopenia is affecting 2 or more of the 3 blood lineages, which are hemoglobin, platelets, and neutrophils. And if you look to the complete blood count of this patient, she has got 3 of those. The 3 neutrophilia, she has got reduced hemoglobin, and she has got thrombocytopenia as well. And of course, hypertriglyceridemia and hyperfibrinogenemia. Fasting glycosides should be more than 3. Usually, they are much more than this. The triglyceride usually reaches up to 8 millimole per liter. Millimole, it's not milligram per deciliter. 5 milligram per deciliter is almost about 400. Sorry, 5 millimoles is almost 400 milligram per deciliter. 11 millimole equals 1,000. So you can do the math yourself, or can use just applications on your mobile or cell phone, just like the MID calculator. In the exam, they're going to give you both units. They're going to give you the millimoles and the milligram per deciliter, so don't worry about it. And then there is histopathological evidence of hemophagocytosis in bone marrow, spleen, or lymph nodes. And then no malignancy detected yet, status unknown. So in this lady, we haven't detected any malignancy yet. So status still unknown, because we're still waiting for the histopathology. So additional diagnostic criteria: reduced or absent natural killer cell activity. And ferritin more than 500. Usually it is thousands, not only 500. Usually it's more than thousands, actually, up to 20 or 20,000. And soluble CD25, and so according to this, obviously the patient is being diagnosed definitely as hemophagocytic lymphohistiocytosis, according and usually and most probably has been triggered by the Epstein-Barr virus. Of course, whenever there is HLH is being suspected, not diagnosed, being suspected, at this point you have to include hematologists and preferably if they have got HLH expert and rheumatologist as well. Because the rheumatologist usually you treat the HLH as well. Of course, it depends according to the policy in your hospital. And of course, you have to consider doing bone marrow aspiration if it is safe to do so. And this decision should be taken, it should be a multidisciplinary team decision, and the hematologist should be involved. And diagnosis may then be made on clinical probability. The H-score is much simpler. It only depends on the temperature, organomegaly, number of cytopenias, triglycerides, fibrinogen, ferritin, hemophagocytosis in bone marrow aspirate if present, serum ALT, or non-immunosuppression status, whether HIV or long-term immunosuppressive therapy. And that's why if the total score is more than 169, then sensitivity is 93% and the specificity is 86%. This is an example of the H-score, which is usually being used in adults. It's much more simpler, as you can see, than the HLH 2004, because usually in the children, we have to think about genetic or familiar causes. But in the adults, most of the cases are acquired whether due to the lymphoma or Epstein-Barr virus. In Epstein-Barr virus, we have to think about both Epstein-Barr virus and the lymphoma caused by the Epstein-Barr virus itself.
Steroid.
I've seen a lot of participants now. No one wants to step in. Just imagine this patient. You have this patient now in the ICU. What are you going to do with them? I'm sure that you have got a lot of patients that you don't know their diagnosis yet. What are you going to do with those patients?
Corticosteroids for immunosuppression, they are the first line of treatment for this. Dexamethasone should be started. And then the supportive care, we need to manage the falling blood hypotension, start vasopressors, and for worsening, we have already intubated this patient. So maybe the patient may go high risk of going to ARDS, then lung protective ventilation strategy should be sought. Low tidal volume and high respiratory rate, high PEEP, optimum PEEP for this patient.
Okay. So Priyanka, you mentioned most of the things what we are going to do, but just my advice to you, just to always try to, in this kind of questions, try just to be systematic you were systematic when you answered all the previous questions. Just in this question, try to be systematic again. You mentioned steroids, then supportive, and then you go into the ventilation and the hemodynamics. Try it first, supportive. We are intensivists. We are not hematologists. We are not rheumatologists. The first thing we are going to do as intensivists is supportive therapy. Maintain the airway, lung protective ventilation, maintain the hemodynamics, and then multidisciplinary team approach. They like this kind of MDT approach or multidisciplinary team approach. They like this word. Okay, you are going to consult hematologist. You are going to consult rheumatologist if needed, or HLH specialist, and then you are going to initiate the appropriate therapy accordingly, whether steroids or any kind of specified anti-specific therapy. Anyone knows any sort of specific therapy for HLH?
Can I add broad spectrum antibiotic in this according to differential diagnosis before diagnosis HLH?
Great, Salah.
Can I add?
That's yes, you definitely. And most of those patients ended up by being on a high spectrum or wide spectrum antibiotics, actually, including antiviral and antifungal as well, for two reasons. First, because especially if the cause of HLH is not known, because HLH can be caused by any form of sepsis, whether fungal or bacterial, not only viral. In addition, the patients are going to receive very immunosuppressive therapy. So they should be covered by this kind of strong antibiotics in order to protect them from any infection which is already being there but not diagnosed yet, or any new infection which they may acquire inside the ICU. And of course, the ICU is a rich medium of microorganisms, and if they acquire any kind of hospital-acquired or ICU-acquired infection, it's going to be fatal for them, especially on this kind of immunosuppressive therapy that they have. So yes, of course, we are going to use give wide-spectrum antibiotics pending the cultures and investigations. Some hospitals, of course, this should be an MDT decision, not one person decision. The hematologist should be on board. The Microbiologists or infectious disease specialists should be on board. Rheumatologists as well should be on board. And of course, all of these are being orchestrated by you, the intensivist. So, where is the me? Sorry. Yes. So, as mentioned by Priyanka, supportive care, consideration often to oral consideration often to give oral antifungal cover, co-trimoxazole prophylaxis, antiviral coverage, and especially if there is no etiology. Sorry. Depending on viral etiology suspicion, because if you have got experience dealing with hematology patients, especially those who are on leukemia or lymphoma, are given immunosuppressive management. They are being given all of them. They're giving oral antifungal. They're giving co-trimoxazole prophylaxis to prevent PCP or pneumocystis carinii infection, and antiviral management as well to prevent any herpes viral infection as well. Most of them end up by being on fluconazole, co-trimoxazole, and acyclovir. But the specific management for HLH usually needs more than this. They are usually given either rituximab, especially if it's driven by Epstein-Barr virus. Rituximab is an anti-CD20 genetic engineered agent, which is being used a lot now in the lymphoma and hematological malignancies, and in HLH, some sort to reduce the inflammatory response, or anakinra. Sometimes they're being given both. Anakinra, which is interleukin-1 receptor antagonist, being generated or being synthesized by the E. coli. And they are not going to ask you about deep pharmacological data in the exam, but they might ask you about the mechanism of action, or about sometimes about the famous side effects or the very well-known common side effects of certain medications. So try at least to know a little bit of information about any medications that are very commonly using in ICU. But don't worry if you cannot answer this kind of question. For example, if you say that rituximab is a biological agent being given to people with hematological malignancies like lymphoma and leukemia, they might accept this kind of answer. They're not going to fail you because you don't know the deep pharmacology, because actually you are always working with the other team members who are expert in this kind of the medications. And there will be clinical pharmacists on board as well. But just try not to keep silent and try to reduce, I don't know, as much as you can. Just imagine that this is a family member and asking you a question. If anyone asks you now, one of your family members or a family member of a patient asks you what is rituximab or anakinra, the first comment to your mind, it's a kind of a specific management, biological treatment, novel biological treatment, which is being given to the patient with hyperinflammatory status, autoimmune diseases, or hematological malignancies. This is the first thing will come into your mind. So don't be ashamed to say this even in the exam. And of course, the second line, what's called etoposide, particularly for malignancy, it is kind of the cytotoxic medication as well, works on the DNA. And maintenance, those patients might need maintenance as well, which is usually going to be by the cyclosporin. And of course, the IVIG are common to be given also in those kind of patients, especially if they have got infective etiology, which exacerbated or caused this kind of HLH in the first place. And of course, as I mentioned, treatment of underlying cause is crucial when identified, if you can identify it. If there is a cancer, treat the cancer. If there is a biological therapy, stop the biological therapy which caused this. Or if there is a specific pathogen which caused this, we have to target it. Epstein-Barr virus, most of the time, they don't give antiviral treatment for it. Most of the cases, but sometimes in severe cases, if there is overwhelming severe infection, they might initiate antiviral management for it. even if it is not specifically against anti-Epstein-Barr virus, like ganciclovir. Ganciclovir is usually for the cytomegalovirus, not for the Epstein-Barr virus. But sometimes they give them a ganciclovir for Epstein-Barr virus. But of course, this decision shouldn't be intensivist only decision. The infectious disease should be on board. The microbiologist should be on board, and this should be pronounced clearly in the exam that you are all these kind of decisions you're going to take with the microbiologist and the clinic and the hematologist. And whenever they ask you this kind of question, for example, if the patient is allergic to penicillin, what are you going to do? And you don't know the alternative, always say this. Always save your skin by saying, I'm going to ask the microbiologist or the infectious disease. Don't be ashamed of asking for a second opinion, even during the exam. Okay. They are not going to ask you in the exam what is the prognosis of HLH or what is the prognosis of any disease or any condition you're going to face. They are going to ask you in the form of the family now, the parents now come to you or the family members coming to you and asking you what is the outcome of this condition. How we are going to answer them. Anyone would like to step in? Salah, would you like to answer? Hello? Priyanka, would you like to answer this question?
Yes. So prognosis of HLH is usually not good. It is a fatal disease, and often the course of the illness is not good. So I would like to take into confidence the relatives, and I would like to understand their dilemma and their mindset. Also, I would like to arrange a multidisciplinary team meet with a hematologist and infectious disease specialist for better explanation to the patient, and I will give a guarded prognosis to the patient family.
Great. That's what that's a good approach. That always try to include some other members with you, some other experts in this kind of condition, and give them some sort of, don't give them so much hope, and just show how the gravity of the condition is, okay? Especially, and always it depends upon usually in the prognosis of the HLH depends upon the patient's background, whether age, previous immunity status, and the cause of the HLH itself, the primary cause of the HLH. Even if you don't know the numbers, this could consider a good answer. So the prognosis is usually 40% acute mortality, 80% acute mortality in malignancy-associated HLH with 5-year survival less than 5%. ICU patients usually 52 to 68 hospital mortality, which is a very high percentage. Mortality worse with shock or severe thrombocytopenia, and of course ferritin as well directly correlates with the mortality risk. Rapid fall in serum ferritin with treatment associated with favorable short-term outcome. So now we have treated HLH. The patient, thanks to God, has got better. We stopped the vasopressors. The patient is hemodynamically stable. She is in minimum settings, mechanical ventilation. She was intubated for 7 days on midazolam and alfentanil. Her hemodynamics are stable. The lab investigations are improving, and your junior colleague is considering extubation. What are you going to do? Any participants?
Initially, assessment of hemodynamic stability. If patient is hemodynamically stable, and if the primary condition which we are dealing with is cared of, and
Sorry,
then
consider. Could you repeat it, please? After the hemodynamically stable, could you?
Hemodynamically, patient is hemodynamically stable. Then
yeah.
we had intubated the patient in view of respiratory distress. If the respiratory distress is settled down, oxygenation is good. The patient is neurologically conscious oriented, obeying, and can lift the neck easily, can elevate the arms, and oxygenation is good, then we can try the extubation.
Okay. Any other objective criteria of weaning other than the thing they already mentioned, other than hemodynamic stability, oxygenation, and physical power? Anything else you'd consider? Whether clinical or investigation, any other investigations, or
Okay, I will put
mechanical? Hmm?
okay. I will put this patient in the weaning in spontaneous breathing trial. I will check hemodynamic stability. After that, ABG for BO2, BCO2 for anything related to cough and conscious of level of consciousness,
Hmm.
and maybe put in TBs. If the patient good with TBs, maybe extubated after a cough leak test.
Okay, that's good. Very good. Okay. Any other things you are going to measure on the ventilator? Any other parameters you are going to measure on ventilator before attempting extubation?
Yes, can measure rapid shallow breathing index should be less than 105, and maybe use this occlusion barrier should be in the less than 0.1 second, and tidal volume expiratory should be more
Sorry,
than
what's
300.
again? Sorry, the pressure. What's the pressure? 0.1 second.
Occlusion barrier.
Okay.
That meaning, yes, expiration is 100 millisecond.
Okay. Yes.
Or 0.1 second, and
Okay.
another tidal volume expiratory should be more than 300 ml, respiratory rate less than 30, and saturation more than 92, and another parameters, uh, yes, just
Very good. So that's a very good answer. Actually, whenever you are going to be asked about the weaning, they are going to give you asked about this. Whether there is everything now is ready to be all the circumstances are seem perfect for extubation, and you're asking whether you extubate or not. But before extubation, you have to mention what you already mentioned, whether the clinical assessment, the proper assessment of whether it starts with assessment of consciousness, assessment of the airway, assessment of the breathing, assessing of the hemodynamics or circulation, and then the blood gas assessment, like assessment of the ventilator parameters, as you mentioned, whether the rapid shallow breathing index, which is the most important assessment you are doing on the ventilator, or most evidence-based actually, and then the other thing that PO 0.1, with maximum occlusion pressure in 100 seconds, or the vital capacity, or the minute volume, or the negative inspiratory force or maximal inspiratory pressure. So, as you mentioned, clinical assessment for readiness to wean, underlying condition resolved, patient condition optimized, reflexes satisfactory, breathing, spontaneous breathing, strength adequate, as mentioned by you, and FI2 usually less than 40. It's not it's not essential, but preferably, and minimal PEEP, cardiovascular stable, minimal dose of vasoactive medications, obeying commands, and objective parameters: respiratory rate less than 30, tidal volume more than 5 mL per kg, rapid shallow breathing index, forced vital capacity, minute volume, and maximal inspiratory pressure or negative inspiratory force, and of course, as you mentioned as well, the PO1 or the maximum occlusion pressure. What is difficult weaning? This can be question. The question can be asked as well. And if you don't know the definition, it will be very difficult to answer, because it should be memorized by heart, that whether it's separation from ventilator on the first attempt, which is 70% of patient, difficult weaning, extubation 2 to 7 days after initial assessment of readiness for extubation, not after ventilation, after the initial assessment, and prolonged more than 7 days after initial assessment. Okay, this is one of the definitions that you have to know by heart, unfortunately, but it's being asked sometimes, not very common, but sometimes they ask it. Okay, now the patient was extubated successfully after 8 days, airway is maintained, hemodynamics are stable, but conscious level is deteriorating. What is your differential diagnosis? Any volunteers?
First, maybe delirium due to ICU admission, and maybe it is non-convulsive, non-convulsive seizure, and
Yes.
maybe any neurovascular or cerebrovascular stroke or anything.
Okay, so what are you going to do? What's the workup you are going to ask for?
We'll assess by mental state, and we'll do CT, non-contrast CT, and maybe do EEG, continuous EEG for conscious level.
Okay. Anything else?
Possibility of dyselectrolytemia, possibility of uremic
Metabolic
encephalopathy, raised ammonia, possibility
Ammonia.
of IC bleed as patient who was uh, had thrombocytopenia in initial assessment.
Great. That's a really very good answer. Thank you so much for participating. This is this is how the question is going to be asked. Usually, after the patient now have got some sort of disturbed level of consciousness, and then they want an answers for the really good answers for why the patient might have disturbed level of consciousness after being successfully extubated. Of course, the first differential diagnosis will be delirium, but what are the other differential diagnoses of delirium? The differential diagnoses of delirium are actually one of the causes of delirium. It's being always use the acronym delirium itself to help you to memorize it, whether drugs, effect of sedation, or effect of the corticosteroids, because this patient had a lot of causes which might cause a delirium. She had very debilitating illness. She was on steroids for a long time, and she was on the midazolam as well. Electrolyte imbalance or endocrine, lack of drugs or withdrawal of medications. She was on fentanyl, so there might be withdrawal, infection, which she has got, reduced urinary sensory input, vision, hearing impairment, sleep deprivation, immobilization, intracranial, which might be stroke or bleeding or seizures, as mentioned by Salah, urinary or fecal retention, which happens a lot actually. One of the more very common causes of delirium is urinary or fecal retention. So don't be some sort of hasty in taking out the Foley catheter once the patient is being extubated. And of course, other metabolic illnesses like ammoniacal encephalopathy or uremic encephalopathy. So you always have to rule out, before diagnosing delirium, you have to rule out any organic cause of deterioration in the level of consciousness. The bloods, as you mentioned, all mentioned, complete blood count, renal function test, ammonia, blood gas, toxicology screen, and cultures, and always consider the withdrawal, as you mentioned. And of course, imaging, brain CT or MRI of focal deficits or concerns for stroke, and EEG if seizure or non-convulsive states epilepticus is suspected. How do you diagnose and monitor delirium then? The patient has been diagnosed with delirium. How are you going to monitor it? That's an easy question.
CAM ICU score.
CAM ICU. So what's CAM ICU score? And how we are going to use it? Have you seen the CAM before?
So alteration in the level of consciousness. There are several parts to the CAM-ICU score. First is acute change in the course of mental status of the patient, whether the acute change is present. Second is inattention. For that, we ask the patient to follow sequence of letters in Save Heart. And if that is there, then consciousness, altered consciousness, and then we look for disordered thinking. So these are the 4 parts of the CAM ICU score. And for disordered thinking, we ask whether a stone will float, fish in the sea, and so on questions. And
Very good, Priyanka. Obviously, you are very ready to the exam, especially to the clinical case skills, actually. So, clinical case scenarios. That's very good answer, actually. So, the CAM ICU is usually a tool which is being used to early detect and monitor the delirium in the ICU. A patient is deemed CAM ICU positive if they have at least 3 out of 4. So 1, 2, and 3 is positive, or 3 or 4. So 1 and 2 should be positive, 3 or 4 should be positive as well, or 3 and 4 can be positive. So there should be altered mental status, as mentioned by Priyanka. There should be an attention test that squeeze my hands, for example, or detect A in the word save heart or Casablanca. Altered level of consciousness. RAS should be anything other than 0, and or disorganized thinking. Okay? Ask them some simple question. Will a stone float in water? Are the fish in the sea? And then observe their answers. How do you manage delirium then? How are you going to manage the delirium?
so first, there's a supportive management to delirium. So we will try to counsel the patient, maybe give day-night breaks, some music therapy and all. And if not, also family help
Family engagement, yes. Okay.
engagement, yeah, family engagement, that I will encourage family engagement also. And if still not working, then I will resort to the pharmacological therapy. So according to the PADIS guidelines, we should start for acute management of delirium. We should start with dexmedetomidine, if bolus dose followed by infusion, and then we should resort to the antipsychotics. For that haloperidol, but also simultaneously we should do QTC interval monitoring also, and also look for side effects like dystonias with haloperidol. And after that, we should completely avoid benzodiazepines in the management of delirium, because they themselves precipitate, and also electrolyte and any imbalance that should be taken care of. So there is a bundle, delirium bundle called ABCDEF bundle. That should be.
Okay. Great answer, Priyanka. I like especially when you said started with the music. So said that the first thing I'm going to do is the music. That's a very good answer, actually. Of course, as you mentioned, non-pharmacological is the best. Whether to prevent delirium first, of course, you have to prevent delirium first by frequent sedation hold, by reducing the sedation as much as possible, awake trials, spontaneous breathing trials. Try to avoid benzodiazepines, and always keep the environment familiar to the patient as much as we can. So the preventive measures are the best are the best to be done before delirium occurs. But once it's occurred, even if it occurs, the non-pharmacological management are the best to control and treat delirium. For example, if the patient has hearing aid, used his hearing aid. If the patient uses glasses, put on the glasses as soon as possible once the patient is extubated, or even while they are in mechanical ventilator, while they are awake, give them their glasses, give them their hearing aids if possible. Avoid any urine retention or fecal retention. Always be ready for any kind of withdrawal therapy. And one of the good things in your answer, Priyanka, as well, that you mentioned PADIS guidelines, which is very good actually. That means that you are updated and you have some sort of updated kind of knowledge or information. That's really, they are going to impress the examiners by this kind of answer. So we usually, if we are going to the right answer, as mentioned, we mentioned multidisciplinary team in the treatment of HLH. The process of rehabilitation and treating delirium should be multidisciplinary as well, should be multi-component. Non-pharmacological intervention is recommended to prevent and treat delirium, reduce or shorten delirium, reorientation, cognitive stimulation, use of clocks, improve sleep, minimize light and noise, improve wakefulness, reduce the sedation if possible, early rehabilitation, and this is very important, early rehabilitation, reduce sensory impairment, whether glasses or hearing aids. Regarding the early rehabilitation, I forgot to mention it during the weaning. The decision of extubation or weaning is not only your decision, it's not only the intensivist decision. You should always, especially the Europeans and the UK, you always like to use the opinion of other teams involved in the treating the patient. For example, whom we are going to use in treating in the decision of extubation? Which teams are you going to ask opinion for whether to extubate the patient or not? Any opinions? Okay. In Europe and especially in UK, they are using the physiotherapist to do the respiratory physiotherapy or chest physiotherapy, whether the patient is on ventilator or not on ventilator. You can find patient here, even while they are on ventilator, they are moving, they are sitting on a chair, they are doing exercise. So physiotherapist and salt and language therapist are crucial part in any rehab, in any extubation process or rehabilitation process, even after extubation or tracheostomy. Or even tracheostomy. So always try to mention this. Always in any kind of answers, especially regarding the complex kind of management, whether rehabilitation, weaning, always involve other teams. In HLH, because it's complex, you involve hematology, rheumatology, infectious disease, microbiology. In these decisions, always try to involve other teams. Involve the physiotherapist or respiratory therapist. If you have, most of Europe, there are no respiratory therapists. I know in the Gulf, there is a respiratory therapist. In some of the Asian countries, there are respiratory therapists. Most of Europe, they don't have respiratory therapists. The respiratory therapy or respiratory physiotherapy is being done by the physiotherapists themselves, okay? And they usually don't take care of the ventilator. The ventilator is being taken care by the doctors and the nurses, which is really different from what is being done in some of the Asian or the Gulf countries or in North America. So you should be mindful of that in the change of the hospital environment from North America or from Asia. As mentioned by Priyanka, regular assessment using a valid toolcam ICU should be at least doing once or twice every shift. So at least being twice at least per day. And address modifiable risk factors. Identify outpatient medication and restart as appropriate. If the patient was on antipsychotics before being admitted, try to restart it. If they were in beta blockers, propranolol for anxiety, try to restart it. Identify outpatient medications and restart. Assess presence of severity of pain. If there is pain, you should treat it properly. And even of opiates, you can give opiates as well in low doses, because especially if you are suspecting withdrawal. Lowest appropriate sedation if possible, and sedation hold, as we mentioned before, and pharmacological prophylaxis is not recommended. Priyanka said that we should avoid benzodiazepines. Yes, we should avoid benzodiazepines, but it's not absolutely contraindicated. Sometimes, yes, you should say you should avoid. We have to avoid benzodiazepines as much as we can. But sometimes, especially if the patient is very agitated, for example, CAM positive 3 or 4, at this point, they are dangerous for themselves and dangerous to the staff. At this point, you are allowed to use benzodiazepine in the lowest possible dose to keep the patient calm. Okay? Especially in the case of withdrawal or severe agitation, at this point, you are allowed to use benzodiazepines. Okay? So it's not absolutely contraindicated, but should be avoided when possible. Medications for delirium, as mentioned by Priyanka, adequate pain management is the first line of medication. Adequate pain management, consider pain management team review. You should be involved as well, especially if the patient has been on the opiates for a long time, more than a week. They should be consulted. Psychosis, first line is haloperidol. And then in the case of agitation and anxiety, you either use clonidine or dexmedetomidine. They are both similar medications. They are both alpha stimulants. Dexmedetomidine is more selective, but the issue that it's not being used, some ICUs don't use it because it's very expensive. and so they are trying to limit its usage at the moment. For most of them either use clonidine either orally or IV. In some patients, especially if the patient has been on tracheostomy or need prolonged or post cardiac surgery or cardiac patient, they sometimes use dexmedetomidine because of its selective ability. And of course, don't forget the olanzapine. Olanzapine, one of the atypical antipsychotics, which can be used a lot, which is being used a lot actually in UK and Ireland as well for treatment of delirium as well. In addition to, especially if the patient now can be shifted to oral medication. I know that some countries have got haloperidol oral, but in most of the European countries, haloperidol is only IV or IM. And only the olanzapine is being have both. There is IV and oral preparations of olanzapine. Follow-up plan. What is your follow-up plan for this patient once it is being discharged from the ICU? Any thoughts? Anyone would like to volunteer? Almost there. John, your microphone is unmute. Would you like to step in?
No
John?
idea, sir. No idea, sir.
What is follow-up plan? Once the patient discharged, are you going to leave him to be managed by the medical team alone?
So follow-up OPDs is a concept. We can always ask the patient to come to the outpatient department. Maybe
Great. Very great. Follow-up. What we call the follow-up OPDs?
follow-up clinic,
Follow-up post-ICU clinic. Follow-up post-ICU clinic. This has been asked before in the exam, okay? Regarding the post-ICU clinic, I know not all of the hospitals have those kind of clinics, but a lot of hospitals now in the UK have got those kind of clinics, and obviously the studies so far were very encouraging. So, as I mentioned before, now the British are being involved very deeply in the EDIC exam. So they are asking this kind of questions in the exam. They are asking about the post-operative clinics. Okay, so expect these kind of exams to questions to be asked in any patient, whether trauma or anything else. So while the patient is in ICU, we will have to at least follow them up for at least the first 48 to 72 hours, because obviously one of the quality improvement and quality management some sort of paperwork which are being done in all the ICUs all over and everywhere, whether in Europe or not in Europe. What is the rate of readmission? One of the quality improvement as a QI assessment projects always is to document what is the rate of readmission into the ICU after being discharged. Because if this ICU have got a high rate of readmissions, that means that they have something wrong with the process of discharge from the ICU. Okay, so always have, and that's why they are using now what's called the post-ICU outreach team. Most of the hospitals are post-ICU follow-up team. Once the patient is being discharged from ICU, is being followed by a post-ICU team to be sure that the ward patients have got all the help and the support they need, and they know how to deal with the newly discharged patient from the ICU, because some of those patients may be challenging to deal with. So always remember post-ICU outreach team, ward rehabilitation, involve the physiotherapist, the swallowing and language teams, because most of those patients will have some sort of dysphonia or problems in swallowing after the extubation. Pain management and psychology, of course, should be involved as well. And as mentioned by Priyanka, post-ICU clinics or OBDs. Of course, these are my reference. And of course, and this is my email if anyone would like to any more resources. My advice to you, if you want to really see a lot of clinical cases, there is a FECAM. I'm going to share it on the chat box. There is a FECAM website where they have got a case of the month, so we can use this. You can use this to see a lot of cases which might become in the exam as well. Because as mentioned, most of the examiners now are British, and the British now are being involved a lot in the questions being asked for political reasons. The SICM are using a lot of British examiners at the moment, and the British are being involved as well in the process of exam questions. And I could feel, because I have passed the EDIC recently, so I could feel that these kind of questions are similar to the kind of questions which are being asked in the fellowship exam as well. So obviously there is a lot of interaction now with the British, because obviously the number of candidates who are applying for the exams has doubled after the GMC started to recognize the EDIC as a way of registration, or as a way to get to finish the CSER or portfolio pathway to be a consultant in UK. So feel free to message me whenever you want to. I'll write my phone number as well if you want to WhatsApp me anytime for any advice. I prepared actually two cases, one short case and one long case but obviously we have passed the time now. We ran out of time, but I'm happy to be asked any kind of questions if you'd like to at the moment. I hope that it was useful for you. This session was useful for you. Any questions? Any questions? Okay. Thank you so much for listening, and sorry for bypassing the scheduled time, which was supposed to be 1 hour. And thank you so much for your engagement, and I hope it would be useful. See you soon. Thank you.